Housing a rapidly expanding, dense mass within a closed fluid system creates a very specific underlying mechanical conflict. By the third trimester, the gravid uterus holds a substantial volume of amniotic fluid, a growing fetus, and the placenta, resulting in a heavy, centralized load. While we typically associate lying flat in bed with total physical rest, internally, this posture introduces an intense physical load on the mother's anatomy. When resting in the supine position, flat on the back, individuals often experience sudden dizziness, bouts of severe breathlessness, and disrupted sleep cycles. These symptoms are often dismissed as routine pregnancy fatigue or general musculoskeletal discomfort, but they are primary indicators of a systemic mechanical vascular bottleneck. Positional shifts during sleep represent a mandatory protocol of hemodynamic management, ensuring the maternal circulatory system remains unobstructed. To understand why this bottleneck occurs, we must examine the baseline vascular architecture of the maternal torso. This 3D vector model isolates the inferior vena cava, or IVC, moving alongside the maternal lumbar spine. The IVC is the primary venous return pathway, responsible for carrying deoxygenated blood from the entire lower half of the body back up to the heart. It shares this tight central corridor with the descending aorta, the major artery supplying oxygenated blood to the lower extremities. Notice the asymmetry. The IVC does not run down the center, it is distinctly offset to the right side of the spine. As a relatively thin-walled vein, the IVC rests directly against rigid bone, making it highly susceptible to external pressure. In a non-pregnant anatomy, this specific placement is highly efficient and operates completely unobstructed. The architecture functions exactly as designed until a massive load is positioned directly above it. In the third trimester, the heavy uterus becomes an intrusive load hovering directly over the central corridor. When a pregnant individual lies flat on their back, the physics of their internal cavity shift. The vector of gravity pulls the mass of the uterus straight down toward the spine. This transverse cross-section illustrates aorticocaval compression. The uterine mass drops downward, physically crushing the inferior vena cava against the rigid spinal column. At this exact point of mechanical interference, the thin vein wall is forced to deform and collapse under the weight. This graph charts the consequence. Fluid velocity within the narrowed vessel drops dramatically. Outwardly, the sleeping patient appears completely still, but internally, the circulatory system is rapidly decelerating. This lack of venous return restricts the volume of blood reaching the right atrium of the maternal heart. Resting in the supine position allows simple gravitational force to mathematically choke the body's primary blood return mechanism. This localized mechanical pinch triggers a systemic cascade. Because venous return into the heart drops, the mother's cardiac output must proportionately drop in response. This split-screen simulation shows the secondary target of that dropped cardiac output, the placenta. As blood flow slows in the compressed IVC, the vascular branches in the placenta lose their volume and pressure, resulting in compromised perfusion. This drop in perfusion pressure directly throttles the rate of oxygen exchange down to the fetus. This condition, diagnosed as supine hypotensive syndrome, reduces oxygenation while the mother remains asleep and unaware. Eventually, the mother's body generates delayed warning signals, a sudden rapid heartbeat or severe breathlessness, that finally break the sleep cycle. Optimal fetal oxygenation relies on the clearance of the maternal spinal corridor. Resolving this systemic crisis requires simple spatial manipulation to redirect the pull of gravity. The positional countermeasure is the left lateral decubitus position, more commonly known as sleeping on the left side. This 3D model demonstrates the biomechanics of a 90-degree leftward rotation. The uterus mass falls forward and left, completely clearing the spinal column. The right-aligned inferior vena cava is released from the mechanical load and expands back to its full circular volume. Venous return is immediately restored, leading directly to a stabilized cardiac output. A fully cleared pathway also improves renal clearance, allowing the kidneys to filter maternal and fetal waste efficiently. The right lateral position is frequently considered as an alternative sleep posture. Resting on the right side is clinically acceptable and maintains a safe environment for the fetus. However, resting on the right side keeps the heavy uterus closer to the right-aligned IVC, making it slightly less optimal for maximum fluid clearance than the left. The left lateral decubitus position specifically leverages the body's asymmetrical anatomy to maximize systemic fluid flow. Maintaining this specific orientation while unconscious requires shifting focus from internal hemodynamics to practical structural management. Nocturnal shifting is an autonomic reflex. Waking up in the supine position is inevitable. If you wake up flat on your back, no panic is required. Simply execute a deliberate mechanical reset to your left side to restore flow. Pillows and supports serve as structural biomechanical wedges that stabilize the pelvis and spine in a lateral orientation. A wedge placed firmly between the knees prevents the upper leg from dragging the pelvis forward into a compromised downward twist. Lumbar support behind the back prevents the spine from rolling backward into the supine angle during deep sleep phases. Controlling pelvic rotation ensures the internal vascular pathway remains completely open throughout the night. The precise physics of the inferior vena cava directly dictate the rate of fetal oxygenation. Managing late gestational sleep requires mastering fluid dynamics and gravity, ensuring optimal conditions for fetal development.